Examination of thorax and lungs. We'll begin the examination of the chest by noting the shape of the chest, symmetry, any kinds of bony deformities. We'll observe the rate, rhythm, depth of breathing and listen to any audible sounds of breathing that may indicate respiratory distress. Now listen and count the number of breaths per minute. A resting adult breathes easily, quietly and regularly for about 14 to 20 times a minute. Inspect the patient's neck for retraction of the accessory muscles, namely the supraclavicular, the sternocleidomastoid, the scalene muscles, suggesting respiratory difficulties. Palpate in the sternal notch to check the position of the trachea. It should be in the midline. Check the patient's color for circumoral and nail bed sinuses, a bluish color arising from deoxygenation. Now examine the posterior thorax, beginning with inspection. Observe the chest for contour, symmetry and deformity. Now also inspect the overlying skin. Palpate the chest wall to locate the areas of pain or tenderness or any lesions or bruises suspicious for rib fracture. To test for chest expansion, place your thumb close to the patient's spine at the level of the 10th ribs and spread your fingers lightly across the lateral thorax. Ask the patient to inhale and exhale deeply and fully while you watch the divergence of your thumbs, normally about 2 cm, and feel for the range and symmetry of movement. Now systematically palpate for tactile fremitus. Feel for the vibrations of tactile fremitus as the patient continues repeating 99 or some similar phrase. Identify areas of increased, decreased or absent fremitus. Palpate and compare symmetric areas of lungs as you identify and locate any areas of increased, decreased or absent fremitus. Continue the examination by percussing the chest in a systematic manner, moving down the thorax, going from side to side as demonstrated in a ladder pattern. Remember, only the distal interphalangeal joint of your flex scimitar finger should be in contact with the chest wall to avoid damping out. Percussion note: we strike with the tip of the third plex or finger. You are trying to transit vibrations through the bones of the plex scimitar joint to the underlying chest wall. Percuss down the chest wall from the apices to the base of the lungs. Listen to the intensity, pitch and duration of your percussion notes and note the sense of vibration. Identify the type of note you are hearing. Normal lungs are resonant. Hyperresonance suggests COPD from alveolar air trapping and delayed expiration. Note any areas of abnormal dullness suspicious for underlying effusion. Next, ask the patient to breathe out and use percussion to identify the lower level of diaphragms. Ask the patient to take a full inspiration and measure descent of the diaphragms or diaphragmatic excursion. Percuss down from the initial level of the diaphragms until you again reach dullness at the boundary of resonant lung tissue and the duller structures below the diaphragm. Excursion is usually 3 to 5 centimeters. Oscillation is the most important examination technique for assessing airflow. Oscillation involves listening to the sounds generated by breathing, adventitious or added sounds. If abnormalities are present, the sounds patient speaks or whispers. To auscultate the posterior thorax, begin at the apices and proceed downward, moving systematically from side to side in a ladder pattern, comparing breath sounds in symmetrical areas. Listen to the duration, pitch, intensity, and the inspiratory and expiratory sounds. Decide what type of breath sounds you are hearing and note any added sounds. Listen to at least one entire breathing cycle at each location. Vesicular sounds: soft, low pitched, heard during inspiration, heard during first, third of expiration, heard over most of lung fields. Bronchial sounds, harsher, louder, higher in pitch, heard over trachea, heard over main stem bronchi. Expiratory sound lasts longer than inspiratory sound. Silent gap may separate sounds. Bronchial sounds. Bronchovesicular sounds, heard in first and second interspaces anteriorly, heard between the scapulae posteriorly, have intermediate pitch and intensity. Inspiratory and expiratory sounds equal in duration and sounds separated by silent interval. If you hear abnormally located bronchovesicular or bronchial breath sounds, assess transmitted voice sounds while auscultating the chest again. Ask the patient to say 99. Normally, the sounds transmitted through the chest wall are muffled and indistinct. The louder sounds reflecting the transmission through airless tissue are called bronchophone. Egophony. E to A changes which occur in lobar consolidation from pneumonia. Have the patient say E. Normally, you'll hear a muffled long E sound. If the underlying tissue is consolidated, the E sound changes to a bleeding A. Examining the anterior thorax. Observe the condition of the skin, inspect the chest for deformity, asymmetry, and respiratory movements. Palpate the chest to locate any areas of tenderness or to assess any lesions or abnormalities. Then assess chest expansion. Place your thumbs along each costal margin with your hands along the lateral rib cage. Observe how your thumbs diverge as the thorax expands and feel for the extent and symmetry of respiratory movement. Palpate for tractile fremitus. Compare both sides of the chest using the ball or ulnar surface of your hand. Fremitus is usually decreased or absent over the preodymus. Next, percuss the anterior chest and the lateral chest. The heart usually produces an area of dullness to the left of the sternum from the third to the fifth interspaces. Percuss the left lung lateral to the area of dullness. Percuss in progressive steps downward in the right midclavicular line. Identify the upper border of liver dullness. As you percuss down the chest on the left, the resonance of normal lung usually changes to the tympani of the gastric air bubble. To auscultate the chest anteriorly and laterally, ask the patient to breathe more deeply than normal. Compare the symmetrical areas of the lungs using the ladder pattern suggested for percussion and extending it to adjacent areas.